Hello everyone, I am Dr.Shakuntala Ghosh. So today I'm going to show you a case of endoscopic tympanoplasty in a middle-aged lady who had left side central perforation. As you can see that it's a medium-sized perforation and it was a dry perforation. The mastoid was completely normal on CT scan of the mastoids and she had about 45 decibel hearing loss in the left ear. So using the 0 degree endoscope which I placed in the canal, I give a thorough irrigation with saline and then I mop all the debris. Then using the curved pick, I make a incision all around the margins of the perforation and freshen the margins 360 degrees. So a complete freshening of the margin should be done without leaving behind any epithelial remnants, otherwise it will lead to residual perforation. Then I put an adrenaline soaked cottonoid in the raw area created to stop the oozing. I keep that packed for about 5 to 10 minutes. Meanwhile, I try to scalpenize the handle of Malleus. So using a curved pick, I am trying to elevate the epithelial remnants of the TM from the superior surface of the handle of Malleus and making the handle of Malleus bare. Using a 0 degree endoscope placed in the canal, the endoscope is a 4 mm diameter scope. Sometimes you can also use 45-degree angle scope to visualize the recesses. So presently I'm doing it using a 0 degree scope and I'm slowly trying to remove the TM remnants present on the superior surface and the under surface of the handle of Malleus. Because I will place my temporalis fascia graft on the handle of Malleus, so it has to be made bare. Earlier I've already harvested the temporalis fascia by a suprameatal incision and my assistant has spread the graft and has made it dry and kept it ready to be placed. So now the entire handle of Malleus has been made bare. Using the curate, I'm trying to make the undersurface of the TM raw and remove any kind of adhesions or coagulum or any kind of infected tissue which may be present underneath the TM remnants all around. While doing this, I must take care in the posterior part and avoid injury to the IS joint. So all around I have made the undersurface of the TM raw so that the graft can be placed underneath and it will adhere well. And if there are any fibrous tissue or coagulum or any discharge or pus, it is removed completely. Here I am visualizing the eustachian tube orifice to see whether there is any disease blocking it. If so, I will clear it. Next, I am using the circular knife and in an anterograde fashion, I am trying to elevate the anterior canal wall flap from 6 o'clock to 12 o'clock position so that I will place the anterior margin of the temporalis fascia graft underneath this flap and anchor it well. This will prevent medialization of the graft which I place. So as you can see that I have made the bone bare and lifting the fibrous annulus and the anterior part of the extra bony canal anteriorly for a few millimeters. I've lifted it. So that in future I will tuck the graft underneath that. Now I place an adrenaline soaked cottonoid below that anterior canal wall flap to achieve hemostasis. In the meantime, I raise the posterior tympanomeatal flap. At 6 o'clock and 12 o'clock, I make radial incisions starting from the TN and coming up to the mucocutaneous junction. With the flat knife, I make these two radial incisions. Up to bone depth, it should be a single firm incision up to bone depth. And then using the circular knife, I join both these two incisions with a horizontal incision up to bone depth again. And width of this should be the mucocutaneous junction. You should not come into the cutaneous part. So as you're lifting the flap, you will realize that the inferior part of the flap is thin, whereas this part, the posterior superior part, is very thick and it requires 2-3 types of to and fro movements with the circular knife to make a through and through incision up to bone depth. This is important so that you don't leave behind any remnants of the mucosa when you're raising the flap. This will lead to, otherwise it will lead to tearing of the flap and epithelial pearl formation. So the flap has to be raised up to the bone depth. As I'm raising the flap, I use adrenaline soaked cottonoids also if there is oozing. So there will be some oozing in the inferior part of the flap as you raise it. So placing a cottonoid there for 3 minutes will stop the ooze. And gently I'm raising the flap of the bony annulus using the circular knife. So I have reached the bony annulus and I'm just teasing the flap of the bone. And I've placed a cottonoid, as you can see, to achieve hemostasis in the inferior part. So I'm lifting, there should be no epithelial remnants in the flap, and you have to separate the fibrous annulus and raise it off the bony annulus. So the fibrous annulus also should come in the flap. It should not be left behind. If it is left behind, then it can lead to mucosalization and epithelial perm formation and also discharge in the post-operative period. So the entire fibrous annulus also should be raised along with the flap. And no epithelium should be left behind. Now I have separated the middle mucosa of the tympanogastric flap, and what I can see is the promontory, the round window. I'm using the curate. If there is any epithelial remnant left behind below the annulus, that also is removed. And slowly the IS joint has come into view. I'm checking the ossicular mobility. You can see that the entire ossicular chain is intact and mobile. And you can see the round window reflex also as I'm moving the palpating the handle of Malleus. This confirms the ossicular mobility. You can see the stapedial tendon, the foot plate. Okay. So now I'm making the bed ready for the graft to be placed. So you can see that there is no disease and the middle mucosa is absolutely healthy. Eustachian tube orifice is also patent, ossicles are mobile, and now the bed is ready for placement of the temporalis fascia graft. So I've reflected the TM flap, posterior TM flap onto the anterior canal wall. And I'm once again inspecting to see that there is no mucosal remnants left on the handle of Malleus. And everything is bare. Now I place gel foam in the middle ear. So first I pack the eustachian tube orifice with gel foam so that there is no medialization of the graft. Next, I pack the middle ear deep to the handle of Malleus, then the hypotympanum, the protympanum with the gel foam pieces. And I also place a cartilage scaffold onto the promontory. This is harvested from the septal cartilage. It's a homograph and which has been preserved in 70% alcohol. So you can see the notch which has been cut for the ossicle so that it doesn't overlie the ossicles. And I place it directly on the promontory. This prevents medialization of the temporalis fascia graft and acts like a scaffold. It is especially useful in case of subtotal perforation. It provides like a support to the graft which is placed. So I stabilize this cartilage, shield cartilage with the help of gel foam pieces all around so that it does not migrate. So one is kept deep to the handle of Malleus, one is kept over the IS joint and also in the notch and all around the cartilage graft. So gel foam pieces have been placed, dry gel foam. Next, I'm placing the temporalis fascia graft which I had already harvested and cut in a rectangular fashion, and it has been dried. And next I slide it gently with the help of the crocodile forceps along the posterior canal wall. I slide it, and the anterior border is first placed underneath the anterior canal wall flap which I had elevated earlier and the anterior TM remnants. And I tuck the anterior margin carefully with the help of periosteum elevator so that no part of the graft gets folded or it is not placed properly. I ensure that it is placed directly on the bare bone and underneath the anterior canal wall flap which I have elevated. Because this is the commonest area of failure of the tympanoplasty with the residual perforation in the anterior part. So one must take special care to tuck the anterior margin of the graft well underneath the fibrous annulus and also overlying the bare bone of the anterior canal under the anterior TM remnants. So extra time should be spent in ensuring this. Next, after I place the graft carefully over the handle of Malleus by overlay, that means underlay but over the handle of Malleus technique. Next, I deposit the posterior TM flap over the temporalis fascia graft and I smoothen out the margins, ensuring that no bare bone is left exposed. And 360 degrees, the temporalis fascia graft has been tucked well. So again, I'm ensuring that the anterior margin of the temporalis fascia just is in close apposition with the anterior canal wall flap. So it is brought upwards and placed under the anterior canal wall flap. This will prevent medialization of the neotympanum. So final check to see that the graft margins have been tucked all around 360 degrees under the TM remnants and under the anterior canal wall and the posterior canal wall flap. I do this repeatedly and ensure that this has been done because a little mistake on our part or carelessness will lead to residual perforation in the anterior and inferior part of the TM, which is a very common mistake done by beginners. So again, I'm pulling out the graft and seeing that it is tucked well underneath it. Because I felt that a part of the graft had got folded. So I pull it out completely and I tuck it again underneath the flap. And now I'm happy. I deposit the anterior canal wall flap back to its place. This has to be done to prevent any blunting of the annulus. So the angle should be maintained to get a good optimum in the post-operative hearing result. There should not be any blunting of the anterior angle. And then I suture the suprameatal incision with Vicryl, 30 Vicryl or catgut. 3 or 4 sutures, full thickness bites are taken and they heal very well. You can see the pre-op, it was 45 decibel hearing loss in the left ear, and post-op, there is almost complete AV gap closure. Okay. Thank you for watching.